Let's get started with endocrine. And you should be thinking like a test question writer. And in the realm of endocrine, there are two areas where you'll get questions. There are two areas where you see patients all the time in your clinical practice. And certainly that's in diabetes and also thyroid disease. So I think you need to be pretty savvy at managing these two diseases. And I think if you are, it'll get you through your clinical practice, but certainly it will get you through what you need to know for your exam. So here's the people who take the exam tell me about the endocrine questions. They tell me, Amelie, I was so disappointed in the diabetes questions. They were so easy. What do you say? Disappoint me, right? They also say, as part of that statement, but you know what was really tough? It was the thyroid questions. So I need to make sure that I get you where you need to be. So let's start by talking about diabetes, and then we're going to ease right into thyroid disease, and we'll take another break. You ready? Let's get going. So everybody knows about diabetes, and you know that in the United States, the most common form we see is always type 2 diabetes. We see loads and loads of it. And in fact, in your primary care practice, you will see loads and loads of type 2 diabetes. What you need to be able to do, because we want to diagnose these people very early, is to know the risk factors. And I think you probably know what they are. But I want you to realize that age is a risk factor. In fact, ADA wants you to screen everybody, not people who are at risk, but everybody who is 45 years of age and older, at least once every 3 years, because age is a risk factor for type 2 diabetes. If you're normal, your number is normal, however we screened you at age 45, then we can wait 3 years to screen you again. But if your number is on the upper limit of normal, ADA says, please don't wait 3 years to screen this patient again, because they want you to find a patient whose glucoses are elevated as early as possible. So one thing for you to realize is that in our risk or list of risk factors, age certainly is one of them. The other risk factors are probably the ones that you thought about first. These are the ones that we see, and it's what usually prompts us to do an evaluation or a screening of a patient who may be at risk for type 2 diabetes. And again, loads of risk factors, so I would be familiar with them. When I told you about screening, I told you that we screen, or ADA wants us to screen according to two things. One is age, which we just talked about, and the other is based on those risk factors, provided the BMI is elevated, 25 or greater, and they have one or more risk factors. ADA wants you to screen these people how often? Annually, right? Annual screening. Every 3 years based on age. You got it? So with regard to screening, these are the latest recommendations from ADA, American Diabetes Association. You should know and have in your memory bank the criteria for diagnosis of type 2 diabetes from ADA. And here's what they are, and I want you to look at them maybe a little bit differently. We used to never use an A1C for screening. It was only used to evaluate and monitor. We now use, as of probably 4 years ago, we now use an A1C for screening, or for diagnosis, We also have, as part of a diagnostic criterion, a fasting blood glucose of 126 or greater. Provided it is confirmed on another day, you can make the diagnosis of type 2 diabetes. Let me go back to number one, because there's something else I need to tell you. When we diagnose a patient with type 2 diabetes, we use these criteria. Criteria number one, when you use an A1C for diagnosis, ADA encourages you to confirm by repeat testing on a different day. When you use number two as a criterion for diagnosis, a fasting plasma glucose of 126 or greater, they want you to confirm it on a subsequent day. Number four, a random glucose of 200 or greater with one or more of the 3 Ps, ADA says, hey, listen, you don't have to confirm that one. If they've got greater than 200 on a random with one or more of the 3 Ps, diagnose them today. Now, I want you to look at the one that I skipped. I skipped number 3. Let's talk about the criterion number 3, and here it is. When we diagnose a patient with type 2 diabetes, a 2-hour fasting plasma glucose during an oral glucose tolerance test is an extraordinarily expensive way to do it. Consequently, we save item number 3 for 2 groups of people. One, our pregnant patients, that's how we screen them. And the other group of people that we use an oral glucose tolerance test on for diagnosis is people who have PCOS that we are evaluating for diabetes. You got it? So when you screen general population or you want to make the diagnosis, we use number 1 with confirmation, number 2 with confirmation, number 4 does not need confirmation, and number 3 we reserve for very special populations because it is so darn expensive. Everybody got it? So these are the criteria. Honestly, they ought to be in your brain. Now, what do you do with those people whose glucose, fasting glucose, is elevated, but it doesn't rise to the level of diabetes? We call those people pre-diabetics. We say they have impaired fasting glucose. Amelie calls these people diabetics in training. That's who they are. They're training to be a diabetic. And unless we turn them around, they're going to end up in diabetes land. And once your ship takes you to diabetes land, it's hard to come back. So we want to turn these people around. And to be honest with you, we have a great opportunity to make a big intervention with these people. So what are you going to do based on initial management? Listen, these are all evidence-based interventions, which is what you ought to be using when you practice. Listen, initial management of a patient that you have just diagnosed with diabetes, these are your 4 big things. First of all, you need to set an A1C goal for them. I'll show you how to do it. The next thing you need to do is reduce as much as you can all of the risk factors that will make them a cardiovascular event waiting to happen. The third thing you need to do is evaluate the use of metformin, and then you do your exam and come up with a plan. So let's talk about that, because that is what you'll do initially when you diagnose these people. Look at the first question I have for you. I want you to know or ask you, what is a reasonable A1C goal for a newly diagnosed patient who has diabetes? Well, it depends on who your patient is. So the question says select all that apply, but I need to make sure you know the difference. For the majority of the general population, ADA says an A1C of less than 7% for an adult with type 2 diabetes is a good goal. Circle number 1. ADA says that for older patients, you don't necessarily need to have them at 7% or less. An acceptable goal, according to ADA, for an older patient is an A1C less than 8%. Look at number 3. An acceptable goal, according to ADA, for a type 1 diabetic is an A1C less than 6%. And according to ADA, an acceptable goal for a pregnant patient is an A1C less than 6%. So one of the first things you will do when you meet your patient and you diagnose them with diabetes is to sit down with them and set an acceptable A1C goal. Everybody with me? These are recommendations from ADA. The next big thing you need to do when you meet and diagnose your patient with diabetes is to look at them and think. They are a pot of cardiovascular risks. And your job is to reduce those risk factors as much as possible. You know why? You know what kills diabetics? It's not their blood sugar. They have vascular events that kill them. That's what happens to our diabetics. So what can you do to reduce those cardiovascular risks? Well, look at my bullets, because this is exactly what you want to work on with them. For patients, especially women who are greater than age 60, men greater than age 50, or anybody with a 10-year risk greater than 10%, when you use your little risk calculator, all of those people belong on what? A baby aspirin a day, right? That's exactly what we want to do. So I want you to seriously consider whether or not your patient who's got diabetes needs an aspirin a day. But the bullet that I have for you down here at the very bottom ought to strongly recommend or make sure that you get those an aspirin in those patients. I don't know why I put it at the bottom of the list, but look at what's at the bottom of the list. Exercise. So listen, when you look at a diabetic patient, I want you to look at them and think, job number 1 for me is to reduce their cardiovascular risks, because that is what is going to kill them. And this is what you need to be all about. Well, I want you to look at this one. What are you going to do for those people whose glucose is abnormal, but it doesn't quite rise to the level of being diabetic? We call these people impaired fasting glucose patients. And ADA says when you find these people, you need to go after them. What do you mean go after them? We need to make sure that if they're overweight, we try to get them to lose weight. We need to get them to move. And ideally, it's 150 minutes of moderate activity a week. But you know what? It's hard to get people to do that. If you can start them out with 10 minutes a day. You know what I usually tell my patients who tell me, oh, Emily, I don't have time to exercise. I'm really so busy. I do not have time to exercise. I tell them, I totally understand. Listen, why don't you, I want you to begin to change your mentality. Park your car as far away from the front door of the hospital as possible. Park your car as far away from the front door of Walmart as possible. And I want you to walk into Walmart or hospital or work or do whatever you got to do. When you leave work in the afternoon, I want you to walk to your vehicle, pretend you forgot something at work, walk back, and then walk back to your car. Do anything you can to increase the amount of physical activity in the course of your day. And once people begin to change their mentality about getting the closest parking place that they can, they'll begin to incorporate more activity. And you know what? That's better than nothing. Ideally, 150 minutes a week would be great. So again, with your impaired fasting glucose patients, you need to be all over lifestyle. But there's something else ADA says, please don't forget. You need to get this patient on metformin. Metformin reduces cardiovascular risks. And you know what else it does? It brings glucose into normal range, and that prevents complications down the road. So ADA says consider metformin in these patients if any one of these criteria are met. Well, you know what? Like everybody I know who's got impaired fasting glucose has one of these. So metformin is strongly urged. You're strongly urged to prescribe metformin in patients who have impaired fasting glucose. Well, you know about evidence levels? When something has an evidence level of A, it's like a grade of an A in school. It means this is what you need to be all about. So listen, metformin is a first choice for oral treatment of diabetes and in fact, impaired fasting glucose get a grade A evidence level, which means consider it. We have loads of data that says that it reduces cardiovascular risks, and you ought to get them on metformin. Now, you ought to get them on a metformin unless there's a contraindication. Look at my question. What's a contraindication for initiating metformin in a newly diagnosed patient with diabetes? Select all that apply. You know what? If somebody had liver disease like hepatitis C, I would worry about putting them on metformin, at least initially. It is certainly a consideration. So I would circle number 1. I'd be worried about that one. Look at number 2, an increased serum creatinine. Can you put metformin in that patient safely? Probably not. Circle number 2. Number 3 says heart failure. You want to put a patient with heart failure on metformin? You might, but you better be very careful. Circle number 3. Look at number 4 as a possible contraindication of use of metformin. It's alcohol abuse. Circle number 4. What happens to someone who binges on metformin? They develop what? Lactic acidosis. What happens to 50% of people with lactic acidosis? They buy a coffin. All right? They buy a coffin. So all 4 of these represent people in whom you should be very, very careful if you put metformin in them. All right? Other than these situations, metformin is a great choice for our diabetics. And here's why. It is one of the only medications that I can think of that we put into a diabetic that does not cause weight gain. It's one of the only medications I can think of, well, really not, but metformin does not produce hypoglycemia. So how does it work? I usually tell a patient when I prescribe metformin for them, I usually tell them, listen, this medication is not going to drop your blood sugar. And they look at me and say, well, why are you giving it to me? I thought you said my blood sugar was too high. It's not going to drop your blood sugar. The way this medicine works is that it keeps your blood sugar from rising inappropriately. Oh, so it won't let it get too high? Right. So you know what that means? You're not going to have those low blood sugar episodes like your friend who's on that sulfonylurea. When you give them a heads up about their medicine and they understand about it, they understand it a little bit more, they're way more likely to continue to take it. Metformin is cheap. I could stand on a street corner and sell metformin. And finally, the best reason to take your metformin every morning is because it reduces all-cause mortality. What does that mean? That means if you get hit by an 18-wheeler crossing the street and you took your metformin this morning, you're less likely to die. That's what it means. So please take your metformin every day. Well, if I've got you convinced to take your metformin every day, here's a question you need to ask yourself. How much is metformin expected to decrease A1C in a patient who takes moderate doses every day? When you write the prescription for metformin and a patient takes it, what change do you expect in their A1C? You expect a drop of 1 to 2%. I want you to circle number 3. So listen, exercise will decrease A1C 1 to 2%. Metformin decreases A1C 1 to 2%. Do you realize what happens when you combine them both? A minimal 2% drop in A1C, maybe even 4%. So I want you to realize that you get a very decent amount of punch in an A1C when you get a patient on metformin. So consider that. Number 3 is your best answer. Well, I'm not kidding you when I tell you what I'm about to tell you. I really wish they would put me on an insurance panel for reimbursement or a Medicare panel to determine reimbursement for people who take care of diabetics. You know what I would do? I would insist on triple the reimbursement for any provider who takes good care of a diabetic. I'm not kidding you. Triple the amount that you get paid for anybody else. You know why? Because if you deliver excellent care to a diabetic, and you ought to be, you got so many things to do and so much time to spend with that patient that you deserve triple the reimbursement. So if I make that thing, you're going to support me? All right, good. I'm counting on it. So look at the things that you must do when a diabetic comes in to see you. Look at this list. You got to do a really good history and physical exam. Look at all the things that you're responsible for checking. I want to talk to you about a foot exam right now. Your diabetics will never realize how important their feet are unless you impress it upon them. Every time a diabetic comes in to see you, every 3 months or whenever it is, you need to make sure you pull off their shoes and socks. Some days I feel like a shoe salesman. I really do. All I do is fool with feet. When a patient comes in who's a diabetic, the first thing I typically do is take the palm of my hand and put it right under the sole of their foot. You know what I'm looking for? I'm looking for an arch. I got to get this patient moving. I got to get them walking. Most people can walk. If they have no arch, I have some interventions I need to get going. If they have an arch, good. The next thing I typically do is take my other hand, I put it on top of the foot, and I'm palpating for a pedal pulse. And that's when I usually make eye contact with Mr. Boudreau, and I say, Mr. Boudreau, I'm checking for a pulse in your foot. You know, diabetics have problems with blood flow in their feet. You know that, huh? Use it as a time to educate your patient. Then I begin to look between their toes. Now, this is where it really gets sticky. You got to tell a patient what you're doing, because if you don't, they're going to think you have a foot fetish, right? So you got to tell your patient, Mr. Boudreau, I'm checking between your toes to see if you have any athlete's foot. You know, you ever have athlete's foot, Mr. Boudreau? Sometimes that means your blood sugar is very high. If you start having that, you need to make sure you really pay good attention to your blood sugars, or call me. Look at the nails. You need to make sure that they have sensation in their feet. When you spend that much time talking and fooling with a patient's feet, they get it. All right? They get it. And you need to help these people get it, because it is expensive when you lose a toe and half a foot and all the foot in the bottom of the leg and in the leg. So you need to impress that upon your patients. Look at all the things that you have to do when they come in to see you. Do you agree that you ought to be paid triple? You should. This is a load of work to take care of in a patient. Well, ADA says that diabetics are best cared for not by a single person, but by a team, which means that when you diagnose them, there's some referrals that ADA wants you to make. You must make a referral for a dilated eye exam. Yeah, this is what I want you to do. I want you to pull your ophthalmoscope light off the wall, and I want you to do a fundoscopic exam. You probably won't see a darn thing. But one day, you're going to see what it looks like in the book. So keep doing those exams until you get it. If this woman is of childbearing age and her A1C is 9.8%, is this a good time to get pregnant? Not a bit. You need to have that conversation with her. And then finally, diabetes is so easily benefited when patients know what to eat. ADA says you need to make a referral to a dietitian or certainly somebody who can help this patient figure out what they've got to eat. So referrals and diagnosis, these are three big ones. So first agent, heavily evidence-based. What do we give initially? Metformin. What are you going to do when metformin no longer gets the A1C where it needs to be? ADA says you must consider a second agent, and this is what they want you to do. They want you to match your patient characteristics with a certain medication, and we have several medications we can give them. So here's the question. Metformin plus what other medicine? What medicine will you add to the patient's metformin? Well, I'll tell you, ADA reminds you to check or choose a medication from another class based on these things like cost, maybe side effects, like I drive a bread truck and there's no way I can be hypoglycemic, Amelie. If I run into somebody, I'm going to lose my job. So you need to find out from your patient, can they afford the medication you're about to give them? What side effects are completely intolerable for them? So have that conversation, and it will help you figure out where to go with them. Now look at the meds. I made a chart for you because people have difficulty and they struggle with wrapping their arms around diabetes medications. And to be honest with you, it used to be so easy. We had metformin or sulfonylurea, and we had insulin. But now we have plenty of other meds. And in clinical practice, in many of your patients, any of these are a possibility. I made a chart for you to help you become more familiar with these meds. So look, these are the different drug classes. The ones you need to be all about for your exam is biguanide. We only have one example, that's metformin. You need to know all about it. The second class you need to know all about for your exam is the sulfonylurea. I've given you some names that will help you recognize them if you see them on the exam. The third one that you need to be all about on your exam is going to be insulin, all right? And I'll show that to you in just a minute. Let's go back to the sulfonylureas because we haven't talked about those yet. The sulfonylureas, as you know, are called secretagogues. You know what that means? A secretagogue does this. Look, it kicks the pancreas. It says, pancreas, give me more insulin. And what happens? The pancreas says, I'm tired of being kicked. You want insulin? All right, I'll give it to you. Whoosh. And it squirts out all this insulin. What happens? It's the most common side effect we see with the sulfonylurea. Hypoglycemia, because you get these squirts of insulin that drop blood sugar. So that's one thing you need to know. What about what it does for an A1C? When you give a patient a sulfonylurea, excuse me, how much should you expect an A1C to drop? 1 to 2%. So all of these things become additive. And again, important point about the sulfonylureas. Another drug class that I don't think you will see on your exam, but you certainly have the potential and the option to prescribe it in practice, is a DPP-4. These drugs are called the gliptins. And those are things like Januvia, Tradjenta, Onglyza. Look at how much they decrease A1C. About 0.7%. Are you impressed? That's not a whole lot compared to metformin or the sulfonylureas. And to be honest with you, they're pretty darn expensive. But certainly you have the potential to prescribe this. One advantage of the gliptins is that they do not produce hypoglycemia. Exactly. What about the TZDs, the thiazolidine diones? There are two of them on the market. One is called Actos, the other is called Avandia. Both of them are generic now and can be prescribed. These absolutely are contraindicated in heart failure. So when I talked this morning about not putting a diabetic on a medication that would worsen their heart failure, specifically the drug class I was talking about are the TZDs. I want you to look at this. If you put a patient on an Actos or Avandia, look at how much it reduces A1C. Are you impressed? Not a lot. All right, so that's an option for you. This is an option that has good evidence for use by ADA. It's evidence level A, and it happens to be the GLP-1s. Those are the injectable drugs like a Byetta or a Victoza. And the way that these drugs work is that they increase the production of insulin when you eat and your blood sugar goes up. That's how they work. An advantage of these is that they produce what? Weight loss. Look at how much they drop A1C, about 1 to 1.5%. So decent, but again, they have to be injected. So I made a chart for you because I think charts are an easy way to look at a lot of information. So what I did was give you the different classes of diabetic meds. I've given you why you might give them. I've given you a good reason not to give them. And I've put something in comments for you that ought to let you or make you remember something very important about the medication. So once again on your exam, you need to know about metformin. You got to know about the sulfonylureas. And you got to know about insulin. All right? Now, let's take care of some patients and see what you'll do with them. Here's your first patient. Mr. Jones is an active 60-year-old retired patient who was diagnosed with type 2 diabetes about 6 months ago. What's an appropriate action today according to ADA? Let's look at his labs and see what happened. You diagnosed him 6 months ago, A1C 8.5%. You put him on 500 twice a day of metformin. You had him come back 3 months later, which is a standard of care, recheck an A1C 3 months later. It had dropped to 7.8%. We didn't get the drop that I would have expected. You increased his metformin now to 1,000 twice a day. You brought him back today, which is 3 months later. Look at the A1C. Like, Mr. Jones, are you taking your metformin? Yes, I'm taking it twice a day. You ever miss it? No, my wife puts it in my cup for me and I take it twice a day. My question to you is, what do you want to do with this man? He's exhausted what we can do with metformin, and in fact, his A1C is going up. Is anybody interested in, or is it a consideration that you start him on basal insulin? It is certainly a consideration. It might not be what I do with him, but it's a consideration. Look at number 2. Add 2.5 of glyburide. What class? A sulfonylurea. He's 60, a sulfonylurea. I'm okay with that. What about number 2 as a consideration? Yes. Look at number 3. Wait 3 months and recheck it. That is not a consideration. He is not at A1C goal, and ADA says you better go after that A1C goal. So not number 3. And recheck it today. You know what that tells me? You don't believe what you got. Really? What you thinking? I believe the A1C I got. Really? So what would I consider? Number 1 and number 2. Everybody see where you're going? Well, let me ask you. Once you start throwing medicines in the same pot, like you start combining all these different meds, are you worried about having an explosion one day? Because really, you ought to be. So listen, I made something for you that I think will help you realize what meds you can combine. You should feel very comfortable in combining metformin with any other diabetic med. Those are always safe. You can combine insulin, obviously, with metformin. You can combine insulin with the GLP-1 agonists. You can combine insulin with the DPP-4s, the SGLT2s. Hey, what are the SGLT2s? There's a new commercial on TV. The name of the drug is Invokana. How do you get rid of glucose when you're on an SGLT2? You dump it where? In the urine, exactly. So you could combine insulin with any of these. Here is something I think you should put in your brain for practice and for your exam. We usually discontinue a sulfonylurea after we start insulin. We usually discontinue a sulfonylurea after we start insulin because the patient gains way more weight. If you leave them on a sulfonylurea, and you know what else? Using insulin alone not only improves the A1C, but you can do it at a lower cost. You got it? So drop the sulfonylurea once you begin to add insulin. All right? It's heavily evidence-based. All right, let's go through some scenarios and get you to prescribe for these patients. I want to know, based on this little patient, what medication you might give them. Look at this. I got an A1C of 5.9%, and a patient who is newly diagnosed with impaired fasting glucose, what medication might you want to put them on? Metformin. Look at the second patient. She is a 55-year-old female who is intolerant of metformin. Remember, sometimes patients just can't take metformin because of the GI side effects. Her A1C is 10.2%. What drug does she need? Listen, a good rule of thumb is anytime a patient has a double-digit A1C, they get what? Insulin, right. So what does a patient number 2 need? Insulin. Look at number 3. A 79-year-old male whose A1C is 8.9%, newly diagnosed with diabetes. An elderly patient, first-line agent, metformin is a good one because it does not produce hypoglycemia. You got it? So let me ask you, with this 79-year-old, what's going to be your goal A1C for him? About 8%. Do you think you can get in there with metformin? Yes, metformin's a good first choice. Look at your next patient, a 62-year-old female who takes metformin. Her A1C is 7.9%, and she is on a fixed budget. What medication could you give her to lower her A1C? A sulfonylurea? Yeah, why would you choose a sulfonylurea? Very inexpensive, right? So fixed budget and cost is a big issue. You typically think of a sulfonylurea after metformin. Look at your next patient. A 27-year-old male, A1C of 6.9%, newly diagnosed with type 2 diabetes. What's your first choice? Got to go with metformin, exactly. All right, look at your next one. A 79-year-old male on metformin with an A1C of 7.9%, and he's needle phobic. Well, you know what you won't be able to give him. So let me ask you something. Do we need to give him a med at all? If your goal for him was less than 8%, I would tell him, listen, keep taking your metformin, but we really got to watch your carb intake, Mr. 79-year-old. I don't want your A1C to get higher than 8. So what will we do for him? I'm not sure we need to give him a med. Let's leave him where he is. Look at your last patient. She's a 55-year-old female who takes metformin plus glipizide, what class? A sulfonylurea, A1C 10.2%. I want to know what you're going to do, and it's 2 things. DC the sulfonylurea, and we're going to add insulin. What will you do with the metformin? Keep her on it. You got it? So add insulin, DC the sulfonylurea, continue the metformin. Everybody got it? All right. What we just talked about is all evidence-based. You got it? All right. Let me tell you, every morning when I wake up, I check email. And I typically get a word of the day from Merriam-Webster. I am pretty sure that you will never see Amelie's word of the day in that email. Here's my word of the day. You ready? Cashopenic. Cashopenic is the state of your wallet being seriously intolerant of spending more money on medications. That's the definition of cashopenic. And the reason you need to know that word, it's not a real word, okay? It's a made-up word from Amelie's crazy brain. The reason you need to know that word is because when you have diabetes, it's very easy to become cashopenic. You give all your money for medications. So please, please be cognizant of the cost of those drugs as you begin to prescribe them for patients. Medications are expensive, but diabetic medications are very expensive as well. So the 3 drugs you need to know for your exam: metformin, the sulfonylureas, and insulin. Now we need to talk about insulin, and here we go. When should you consider insulin? Always when you have a double-digit A1C. Always we consider insulin. And certainly in any of these other situations, but ADA has a message to you since 2009. Here's a message from ADA to you. Please don't use insulin as a last resort. We want you to consider it early because of this term. Listen, it preserves pancreatic function. You got it? When you give basal insulin to a patient who has diabetes, it preserves pancreatic function. You know what that means? The patient's pancreas can produce native insulin for much longer, maybe years longer, if we give the pancreas a little bit of help with basal insulin. So consequently, we don't consider insulin, especially the basals, as a last resort anymore. So let's talk about the insulins. You know that we have an option or the ability to prescribe many different kinds. We typically use immediate, in certain situations, mealtime insulin. But the two that you need to know about for your exam tend to be those long-acting ones like NPH and the basal insulins. So let's talk about them. The long-acting basal insulins are drugs like Lantus and Levemir. And I am telling you, I could stand on a street corner and sell these drugs. You know why? Because they're going to make you and me look like a great NP. You know why? Your patient's A1C is going to drop very nicely when you put them on one of these. And you know what else is going to happen? When the patient comes back in to see you, the patient is going to look at you and say, you know, I really didn't want to get on that insulin, but I have to tell you, I feel better. I'm not as tired as I used to be. So you will find that your patients will improve very much when you put them on one of these long-acting insulins, which could also include NPH. So listen, how do these drugs work? Your pancreas squirts out insulin in two different situations. You squirt out insulin called basal insulin every minute of every hour of every day. Every day you squirt out basal insulin. When you eat something, your pancreas squirts out even more to make sure that your blood sugar remains within normal range. These insulins mimic basal insulin. They mimic the amount of insulin you squirt out every minute of every hour of every day. That's why they give the pancreas a break and help preserve pancreatic function. The bottom line is they greatly improve A1Cs, and that's why I could stand on a street corner and sell them. So how are you going to start this drug? Once you arrive at a point of deciding that, yeah, this patient needs insulin, how do you know how much to prescribe? Well, typically ADA says you ought to give about 0.1 to 0.2 units per kilogram as a bolus at bedtime, or you could give the chicken NP dose, 10 units. So listen, how much insulin are you going to start a patient on? You got to give an amount of insulin that lets you sleep at nighttime. That's how much you have to give. If given 10 units at nighttime doesn't let you sleep because you're afraid to bottom your patient out, then you better go with 5. So you're going to have to get your sea legs under you, meaning figuring out how much insulin you can give that lets you rest well at nighttime. Generally, we start at about 0.1 units per kilogram as a single bolus, or we give 10 units. Now, generally, as we begin to increase the amount of basal insulin that we give the patient, that's a starting dose, 0.1 units per kilogram. But as that doesn't hold them and we need to go up, generally we go up by 2 to 3 units every 2 to 3 days until their AM fasting glucose is at our goal. What's going to be your goal? AM fasting glucose, what is it? Less than 130, right? 70 to 130 is your fasting AM glucose goal. So that's how you'll know. So if you start them out on 10 units and the AM fasting glucose is 160, you go up by 2 to 3 units. You get some AM fasting glucoses. If they're at 140, you go up a couple of units. And you continue to go up until you get their AM fasting glucose goal somewhere around 70 to 130, depending on your patient. Once you need better glucose control, we have 2 options. People call one of these options basal plus, which means we give short-acting insulin, the immediate insulin that I mentioned earlier, before the biggest meal. A lot of people will use that to help keep blood sugars down. But there's another option that you have, but this one needs a very motivated patient. It's called basal bolus. We give basal insulin once a day, as we talked about, but these people bolus with immediate acting insulin at each meal. So it means more injections, and it certainly means better glucose control, and it means you need a very motivated patient. So there are other options that we have once our basal insulin doesn't help our patients get the glucose level they need. You with me? So listen, you think you can take care of some diabetics. You got to wrap your arms around the meds, and that's what makes it very tough. So if you're struggling right now, what I want you to do is go look at those tables that I made for you, and I think it'll help you wrap your arms around those meds, and that will make you more comfortable as you prescribe. You ready? Let's talk about thyroid disease. Some people call the thyroid gland the butterfly in your neck. Look at why they call it the butterfly in your neck, because that's exactly what it looks like. So let me show you what happens, or remind you about your physiology. I'm assuming that everybody in this room has a pituitary gland. Okay, like yes? Everybody has one? Okay, good. Everybody's pituitary gland has an anterior and a posterior lobe. The anterior lobe of your pituitary gland squirts out some really important things. And one of those really important things that it squirts out is TSH. TSH is nothing but a messenger. TSH just delivers a message to the thyroid gland from the pituitary gland. And the message it usually delivers is, hey, thyroid gland, make some thyroid hormone. Specifically, make T4 and T3. Are T3 and T4 the same thing? Not at all. In fact, if they let me put a face on T3 and T4, this is what I think T3 and T4 would look like. That's what they look like. So listen, T3 is this big guy right here, and he revs up your metabolism. T3 is what drives your metabolism and mine. T4 is a little 90-pound weakling. You need him. He has to work in concert with T3, but to be honest with you, if you want to rev up somebody's metabolism, T3 is the way to do it. Now, you should know, both for your exam and in your clinical practice, the signs and symptoms of hypo and hyperthyroidism. All right, you just got to know them, and I think you probably already do. Let's talk about hypothyroidism. This is very, very common. We see it more commonly in women, especially older women, meaning 50 or older. The most common reason people have hypothyroidism is from something called Hashimoto's thyroiditis. Do you know what that is? It's an inflammation of the thyroid gland that reduces how much hormone the gland is able to produce. It's an autoimmune disorder usually, and again, on your exam, autoimmune disorders, this may be one that you see. I am willing to bet you that you will see one of these people in your first week of practice. You know why? Because if you see only 50 people, let's make it 100. Let's say you see 100 people in your first week, 25 days a week, 10 before lunch, 10 after lunch, you will have seen 2 to 5 people who have hypothyroidism, because it is just that common. If you only see 10 people a day, you've seen 50 in a week, you should see at least one who has hypothyroidism. If you are willing to tell me right now, would you please raise your hand if you have hypothyroidism? Look around this room. We got a load of people. And the reason we have a load of people probably is because we have an abundance of women in this room, but not necessarily greater than age 50. So you see how common it is? You will run into these people in your first week of practice. So take a look at why we worry about hypothyroidism. What lab abnormalities are associated with hypothyroidism? Well, you know what? When a patient has an abnormal lipid panel, we get a TSH. Because if the TSH is elevated, so will the LDLs be elevated. So they absolutely circle number one. They increase LDL values. With patients who have hypothyroidism and an elevated TSH, we see hyponatremia. In patients who have hypothyroidism with an elevated TSH, we see macrocytic anemias. in the form of an increased MCV. Remember we talked about MCV and MCH yesterday. They increase the size of red cells. And finally, this is kind of bizarre, but you may see an elevated CK in patients with poorly treated or undertreated hypothyroidism. So do you see how an untreated thyroid gland has implications in the rest of the body? Because it certainly does. So identify these patients and get them treated. What about hyperthyroidism? This is when the gland makes too much circulating thyroid hormone. What's the most common form? Graves' disease, right? You're probably going to have to see 2,000 people before you see your first one who's got hyperthyroidism. How long is it going to take you to see 2,000 patients? I'm serious. Suppose you see 20 a day, 100 a week, 400 a month. In 5 months, you will have seen 2,000 patients. So these people walk in your office about twice a year. When the first one walks in, I want you to look at them because they all look alike. They are miserably exhausted. And the reason they are miserably exhausted with hyperthyroidism is because they are on a 24-hour-a-day treadmill that keeps going faster and faster and faster and faster, and they can't jump off. They can't sleep. They can't rest. They can't relax. They are exhausted. In fact, you might be surprised to know that a patient with hyperthyroidism is always more exhausted than a patient who has hypothyroidism. These people are exhausted, and that's the opposite of what most people think. Here's a question for you. A 27-year-old male has suspected hyperthyroidism. How should he be screened? And the key word is screened. Take a look. We get a TSH only, right? So when you screen for thyroid disease, you get a TSH only. If it's abnormal, then you have some things to do. For the purposes of our discussion today, these are going to be our normal values. We're going to say, for the purposes of our discussion today, that a normal TSH is 0.5 to 4.5. For the purposes of our discussion today, we're going to say a normal free T4 is 0.8 to 1.8. So you remember I told you life is about recognizing patterns, right? Anytime you see an elevated TSH, the patient has hypothyroidism. Anytime you see a decreased TSH, the patient has hyperthyroidism. It's the opposite of what you think. Now, what do you do when you get an abnormal TSH? The recommendation from the learned endocrine authorities is this. If the TSH is normal, no more testing. If the TSH is elevated, when you retest, which is always a recommendation, they recommend you add a free T4 because T4 is the thyroid hormone that typically is the one that's out of whack, which is how we supplement these patients. That's levothyroxine. If the TSH is low, what does the patient have? Hyperthyroidism. They suggest that you repeat the TSH and look at what we add, a T4 and a T3. All right? That's a recommendation from the learned endo people. And I'll leave it at that. You got it? So know what to do when you get one of these TSH values. Now, I made a chart for you with some patterns. And these are very easy to see, which will help you make a diagnosis of thyroid disease pretty easily. Take a look. When a patient has an elevated TSH, the T4 is reduced and the T3 is normal, the patient has primary hypothyroidism. What does that mean, primary? It means that the problem is in the thyroid gland. All right, it's not secondary hypothyroidism. So the word primary tells you the problem is in the thyroid gland. When a patient has, subclinical hypothyroidism, this is what they look like. The TSH is elevated, but the T4 and T3 are normal. You will see a load of people like this, but this is the pattern. The third situation that you won't see every day, but you will see about twice a year, is primary hyperthyroidism, meaning the problem is in the gland and it is making, look, too much thyroid hormone. It is always evidenced by a reduced TSH and an elevated T4. You got it? That's the most common presentation. So now you know what the patterns are. Let's look at what you'll do. The most common one that I think you'll see up here is primary hypothyroidism. You run into that all the time. Every week you'll see one of these people. So what are you going to do? The first thing you have to talk about is when you give this drug. We're going to give them L-thyroxine, levothyroxine. The first thing we're going to do is make sure that they know to take this drug on an empty stomach. And honestly, we get better absorption on an empty stomach in the morning than when we get an empty stomach in the evening or in the middle of the night. So the preference is empty stomach in the early morning. An hour before breakfast is ideal. You need to make sure your patient knows that one. So what drug do we give? We give synthetic T4. We give L-thyroxine by mouth every day. Now, here's what you should remember about synthetic T4. It's a prohormone. It mostly is inactive. It doesn't become active until a process plucks away one of those iodines, and it becomes T3, which is the active form, which is what contributes to your metabolism. So once that iodine becomes plucked from T4, it becomes T3, and now it can increase your metabolism. You got it? How much of that do you give? You give 1.6 mics per kilogram per day. So right now, I could calculate exactly how much thyroid hormone you need. So how do you give it? Well, for someone who is young and otherwise healthy, we typically calculate how much they need and we give them the full replacement dose. But here's what I want you to remember. When you give a patient levothyroxine, you know what you're about to do? You are about to rev up their metabolism. So if you have a patient who can't stand to have his metabolism revved up too rapidly because he has arrhythmias, he's got underlying coronary artery disease, he's had an MI, he's got something else going on, you must be very, very careful and deliberate in how much you give them. So listen, full replacement dose for young, otherwise healthy patients. We base it on ideal body weight, not necessarily actual body weight. And finally, you must use your good clinical judgment. So let me give you some examples. How would you replace these people? Well, let's say one of these people walked in your office. Your patient weighs 120 pounds. That's 55 kilograms. If we multiply that by 1.6 mics per kilogram per day, they need 88 mics a day. And today is your lucky day because we have an 88 microgram tablet. And that's what you'll write a prescription for, and we'll see where it takes them. Suppose a patient who walks in your office weighs 150 pounds. They weigh 68 kilograms. When we multiply that by 1.6, it means they need about 109 mics per day. Well, we don't have a 109 mic tablet. We got a 100 microgram tablet and a 112. And now you have a decision to make. Do you want to give them 100 or do you want to give them 112? Well, here's what will help make that decision for you. Is this a patient whose metabolism can stand to be revved up a little too much if that's the direction it goes in? If you tell me, yeah, he's 25 and otherwise healthy, then consider that 112 and see how he does. Suppose it's somebody who's 45 with possible underlying coronary artery disease. I'm going to err on the side of being very cautious with them and hit them with maybe 100. And you know what? I might hit them with less than that. So you use your good clinical judgment when you decide how much hormone to give, because you will rev up their metabolism. So look at this question. A 27-year-old female has been diagnosed with primary hypothyroidism. She asks you, hey, Amelie, how long before I feel better? Because I've been tired for so long. What does Amelie, the new NP, say? Excuse me, I'll be right back. It's like, I don't know. How long does it take before they feel better once you start replacing them? I would tell you they probably are going to feel better in a couple of weeks. They're not going to feel where they need to be. But in 2 weeks, if you were to get them on the phone and say, hey, how you feeling? They would probably answer this: I feel a little bit better. They're not going to feel much better, usually, until the TSH is back in normal range, and at 2 weeks it's not back in normal range. When do they begin to feel better? Probably starting in a couple of weeks. So that's what you do with young, healthy, otherwise healthy people, full replacement dose. What about your middle and older adults? What are you going to do with them? You can't replace them at the full replacement dose usually. This is what most learned authorities will do. Starting at 50 to 60 years of age, we usually start at about 50 mics a day. It's plain old 50 mics a day. Let's see how they do. And here's why we do that. Every single person in this room has underlying coronary artery disease. You've had it since you've been a teenager. The older you get, because coronary artery disease is a disease of accumulation, the older you get, the more underlying disease you've got. So we want to rev up the metabolism very slowly in an older patient. If somebody's got cardiac disease or they have arrhythmias, you better start them at half of that amount. You follow me? 25 mics, you can always give more. But let me tell you why you better be very careful when you add levothyroxine. The half-life of levothyroxine is 1 week. If you over-supplement these people and they're having arrhythmias and tachycardia or chest pain, it's going to take 4 to 6 weeks before that drug gets down to a reasonable level again. So you need to be very careful when you increase or as you go up on their supplementation. One more point with regard to older adults and thyroid replacement. Small decreases in thyroid replacement might be needed as your patient ages. So an 80-year-old is not going to need the same amount as she needed when she was 30. You got it. So you got to watch your patient. And as she begins to decline physically, you may decide to make small decreases in how much levothyroxine she gets. And there's an age difference with regard to TSH. Take a look. The upper limits are normal for a TSH in an 80-year-old. Do you see that it's higher than it is for anybody in this room? So I want you to be cognizant of the fact that as your patient ages, you may need to make some small changes or decreases in how much levothyroxine they get. You with me? You with me? All right, let's keep going. Here's your patient. A patient has been diagnosed with hypothyroidism today. What should be evaluated in order to determine how much levothyroxine to prescribe? Like, what are you going to look at? I'm looking at the age for the reason we just talked about. I'm looking at what comorbids they have. They have tachyarrhythmias, underlying coronary artery disease. Does gender make a difference? I don't think so. What about their actual weight? I would look at it, right? So I think I'd circle number 1, number 2, and number 4. But we replace based on not actual weight, but what? Ideal body weight, exactly. So I would still look at their actual weight. Let's let you prescribe and take care of some thyroid patients. Here's your first one. A 75-year-old female has the following lab values. She complains of fatigue. So look, on screening number 1, her TSH was elevated at 13.5. The T4 was 1.1, normal range. 6 weeks later, you screened her again. TSH is again elevated, 15.6. T4 is normal. My question to you is, what is your diagnosis? What does she have? She's got subclinical hypothyroidism, circle number 2. Well, what do we do about subclinical hypothyroidism? The learned thyroid experts say treatment is very controversial, and there's a good reason why it is controversial. Most people will treat a TSH that is 10 or greater. If the TSH is less than 10 and the patient has subclinical hypothyroidism, most people say do not treat. Continue to follow them every 6 to 12 months unless your patient becomes symptomatic. So here's what happens with subclinical hypothyroidism. These patients go along with subclinical hypothyroidism and they continue to go along, and one day they fall over the cliff. Fall over the cliff means they develop primary hypothyroidism. That's what it means. So look at this question, because this is why we don't do it. A 45-year-old patient who has subclinical hypothyroidism requests levothyroxine for her symptoms. What are the risks of prescribing it? Suppose she's sitting at a TSH less than 10, and she tells you, but Amelie, I'm tired, please give me hormone. Amelie is going to say, I don't want to, because if I give you levothyroxine with TSH less than 10, I'm going to cause number 3, accelerated bone loss, and that's the long-term problem. The short-term problem is I'm going to increase your risk of atrial fib. What's so bad about that? A stroke. So you get it? That is why endocrine and thyroid authorities are reluctant to prescribe levothyroxine for subclinical hypothyroidism if the TSH is less than 10. You got it? We have acute issues like a stroke from atrial fib, and we have long-term issues like bone loss. Number 3. Here's your next patient. A 51-year-old patient has been diagnosed with hypothyroidism. How should her levothyroxine dose be managed today? All right, so she's already got it. 6 weeks ago, you diagnosed her TSH 44.3, T4.2. You started her on 88 mics daily. Today, 6 weeks later, TSH has dropped to 18.4. My question is, what do you want to do with her levothyroxine? Well, the half-life of one levothyroxine is a week. We typically check a drug level 5 half-lives later, which would be 5 weeks. That's why we check a TSH every 4 to 6 weeks. So at 6 weeks later, her TSH is not going to drop anymore if you continue to give 88 mics. We have to give more levothyroxine. She's at 88 right now. Why don't we bump her up to 100? You got it? Why don't we bump her up to 100? How about number 3? Does that seem reasonable? Yeah, let's see what happens in 6 more weeks. Everybody good? You will let me know that you understand thyroid disease if you can tell me what happens in these 4 situations. Let me set it up for you. This is a patient who has hypothyroidism. They are being replaced and their TSH is normal. I want to know what will happen to their TSH if they begin to take their levothyroxine with food. What's going to happen? They're going to absorb less. The TSH does what? It increases. Look at situation number 2. Suppose they look at their watch and they say, today's December 2nd. I'm going on a cruise after January 1st. I need to lose a couple of pounds. I'm going to start taking 2 tablets instead of 1. If they start taking 2 of their levothyroxine instead of 1 a day, what is going to happen to their TSH? It's going to drop, right? Because they will develop induced hyperthyroidism. Look at number 3. Suppose they start taking their levothyroxine with vitamins. They're going to absorb less of their hormone. What happens to the TSH? It begins to rise. And finally, this is going to happen to me with my patients next month, in February, and in March. When they get switched by their insurance company from brand name to a generic form of levothyroxine, what's going to happen to their TSH? Look. You can flip a coin. It can go up, it can go down. If they absorb more of the hormone, what happens to the TSH? It drops. If they absorb less of the hormone in generic form, TSH goes up. So I don't know, you can flip a coin. Everybody got it? If you understand this, you understand thyroid disease. And so you will monitor these people after you get the TSH where it needs to be. You'll monitor them annually unless they develop symptoms, and then you'll bring them in and recheck. I'm almost there. Hang with me. Take a look at this patient. A 27-year-old male reports a recent 12-pound weight loss. He's extremely fatigued, and he tells you, I feel edgy. What's the most appropriate action for the NP? I want you to look at his TSH. What are you thinking? Hyperthyroidism. Blood pressure is elevated, heart rate's elevated, body temperature is elevated. He looks like his lab work. I want to know what you'll do with this man. Is anybody in this room comfortable giving a drug that kills his thyroid gland? No, like radioactive iodine, I'm not there. But he needs to go to endo. How long is it going to take you to get in to see endo? Months. What will you do in the meantime because he's got these symptoms? Why don't you consider some propranolol? And you'll never believe how much propranolol these patients can eat and still have an elevated heart rate. So be prepared to go up and up and up on it. So how about circling number 1 and circling number 3? Everybody got it? Whew. You just went through the worst part of your day. All right? So take a big deep breath. Let's see where you are. If you take ANCC's exam, they might show you a picture. And this might be a picture you see. I want to know what that's called. Acanthosis nigricans. And I want to know what's the significance of that. It always represents, listen to the term, insulin insensitivity. That's what acanthosis nigricans is. So look at this patient. A 35-year-old female was diagnosed with hypothyroidism 6 weeks ago and is being replaced with 88 mics of levothyroxine daily. Based on today's labs, what action is appropriate? TSH is normal, right? T4, excuse me, is a little elevated. What do? What lab value do you use to go up or down on a dose? TSH only. What's with your TSH? It's normal. What do you want to do? Continue the same dose, circle number 4. Don't get tricked by extraneous lab value. Somebody should not have ordered that. A 60-year-old patient has 7.8% A1C on 1,000 of metformin twice a day. What drug class could be considered to achieve better glucose control if cost is a major determinant of drug choice? You want to give a sulfonylurea? And I would say circle number 4, good choice. A 49-year-old male takes maximum doses of metformin daily. His A1C has risen to 10.2%. What insulin could be used to initially attain better glucose control? Select all that apply. Well, we don't usually hit them with regular insulin to get right. Not now. NPH? Certainly a consideration, circle it. What about a basal insulin like Levemir or Lantus? Circle it. We could consider either one of those and not immediate acting, right? So circle 2 and circle 3, they're both good considerations. Look at this patient. A 30-year-old female with a normal BMI has symptoms of hypothyroidism. Her TSH is 35.6. What must be used to determine how much replacement is needed? Well, she's got normal BMI, so I'm probably pretty sure I'm looking at her ideal body weight. We don't look at BMI, right? Circle number 2, and the TSH has nothing to do with how much we're going to give. You calculate it based on her age and also her ideal body weight. So I'd circle number 2. And I think this is our last one. Take a look. The NP is initiating levothyroxine for primary hypothyroidism in a 75-year-old female. Her projected needs are 88 mics a day. Don't take the bait. What dose would be most appropriate for initial therapy in this client? Is not 88 mics. How old is she? 75. How much you want to start her on? Maybe 25? So how about number one? Yeah, how about number one?